Hi, my name is Sophia.
And I'm Emily, and this is our presentation on cystic fibrosis. Next. Cystic fibrosis is an inherited gene mutation that causes exocrine and epithelial cell secretions to be abnormally thick, causing a variety of health issues. Next. Cystic fibrosis, or CF, is an autosomal recessive inherited disorder, which means each parent is a carrier, and each passes one recessive gene to the child. The parents don't usually have the disease themselves, as patients are usually infertile. CF incidence in the United States is 1 in every 3,000 babies, and most commonly occurs in white populations. Next. CF is caused by a mutation of the CFTR protein, a complex chloride channel that regulates the movement of chloride, sodium, and bicarbonate in all exocrine tissues and the epithelial cells. There are a range of possible gene variants of the mutation that may present on a range of symptom severity. This mutation causes less chloride secretion and too much sodium absorption, leading to dehydration on the surface of the epithelial cell and the creation of a very thick, viscous mucus. These viscous secretions are likely to be present in the lungs, pancreas, intestines, and reproductive tract, and cause higher salt content in sweat secretions. Next. Here's a diagram of functional versus dysfunctional processes of CFTR in the airway. Feel free to pause the video here to take a closer look. Next. The most common secondary diseases of CF are lung disease and malnutrition, both of which are caused by the viscous mucus. This mucus in the respiratory tract creates an optimal environment for bacterial growth and airway colonization, responsible for the signs and symptoms listed on the next page. Malnutrition as a clinical manifestation of CF is due to the pancreas. CF patients are susceptible to pancreatic insufficiency, pancreatitis, and CF-related diabetes. The mucus clogs the pathways for pancreatic enzymes responsible for nutrient digestion, specifically of fat-soluble vitamins in the small intestine. This affects approximately 90% of CF patients. Next. The signs and symptoms can include a persistent cough, wheezing, breathlessness, chronic lung infections, recurring sinusitis, bronchiectasis, which is an obstructive airway disease, constipation or frequent steatorrhea, male infertility and possible female infertility, and malnourishment despite normal eating. Next. The majority of CF diagnoses occur before the age of 2, and with current newborn screening before 1 month of age. Newborns are tested with a blood spot test for immunoreactive trypsinogen levels, which, if elevated, diagnosis is confirmed with a genetic analysis and a sweat chloride test. Adult onset CF is often a milder form because of a genetic variant of the genetic mutation and discovered because of clinical manifestations or CF-related disorders. Adults are first tested with a sweat chloride test, which, if found to be abnormal, are further tested and diagnosed through genetic analysis, as the sweat chloride test is not a guaranteed diagnosis for adults. Next. Individuals diagnosed with CF are encouraged to visit a specialized CF center at least once a year for a checkup, or, if they are unable to, at least meet with their physician for coordinated monitoring tests. Ideally, monitoring should take place around every 3 months. With advancing treatments and technology, CF patients have an increased median age of survival, with recent newborns now looking at 61 years instead of 37.6. There are also some cases of CF patients surviving into their 70s. Next. Common medications and treatments. Since CF is a multisystem disease, a multidisciplinary care team works together to manage symptoms, treat deficiencies, prevent complications, and prevent disease progression. Chronic maintenance therapy focuses on preventing airway infections and airway obstructions. Next. Here is a list of the common medications and treatments. Pause the video here to read through the list of common medications prescribed to CF patients. Next. CF patients have variable energy and protein needs. Energy requirements vary greatly depending on the patient's demographics and comorbidities. It is not unusual for requirements to be 110 to 200% of the recommendations for the general healthy population. Next. Routine nutrition screening for CF patients should occur quarterly or as deemed necessary by symptoms. Screening for patients 2 to 20 years old consists of anthropometric measurements to compare growth percentiles and z-scores to population norms as they're directly related to lung function. For adults over 20, BMI is calculated and further action is taken if a male's BMI is under 22 or if a female's BMI is under 23, or if there has been a trend of decreasing BMI. Next. Biochemical indicators. Pause the video here to read through the list of biochemical indicators for CF patients.
Thank you, Emily. I'll be taking from here, starting out with nutrition diagnoses that are commonly seen. First, micronutrient deficiencies include fat-soluble vitamins as it relates to, as Emily discussed, the pancreatic insufficiency from fat malabsorption. So we'll see A, D, and E, A, D, E, and K affected. And some minerals affected as well include iron, calcium, zinc, and sodium. There's also essential fatty acids, which are commonly seen to be deficient in patients, for example, omega-3s and omega-6. So I'll go over just a couple. We don't have time to cover everything in detail, so starting out with vitamin D. Some contributing factors besides malabsorption include inadequate intake, glucocorticoid treatment, low sun exposure, impaired hydroxylation in liver or kidneys, and low fat stores. And for vitamin K, there's an increased risk of deficiency for patients with short bowel syndrome, liver disease, and heavy antibiotic use, which is very common. And then we have iron. Iron deficiency anemia is very common in patients with advanced lung disease. Lungs of CF patients have elevated iron levels. Iron losses in the GI tract and through sputum may contribute to deficiency. And Pseudomonas is a very common CF pathogen that exists in the lungs of patients, and it requires iron as a nutrient. So iron losses in the airways may facilitate this infection. And then for calcium, some contributing factors to deficiency include inadequate intake, inadequate absorption, and vitamin D deficiency. As we know, vitamin D is necessary to enhance calcium absorption. So that's going to be an issue for calcium if they're vitamin D deficient. So there's a long list of secondary conditions that are connected to CF, and we don't have time to cover all of them, but I will highlight just a few of them here. The first one being osteopenia. About 1/3 of adult patients have low bone mineral density in the CF population, and children have higher occurrences of osteopenia compared to the general population. Some contributing factors um, include vitamin D malabsorption, low calcium and vitamin D intakes, corticosteroid usage, and decreased physical activity, such as weight-bearing exercises, pubertal delay, and systemic inflammation from lungs, because when the cytokines are released in excess, they break down bone. So unfortunately, that's an issue for them. And then the second one, very common, is diabetes. It affects 20% of adolescents, and around 50% of patients will develop this by the age of 30. And it's due to the pancreatic destruction and the reduction of insulin from the loss of beta cells. Insulin therapy is the number one treatment for this. It's not typical to see oral, but they use short-term and long-acting insulin therapy, which is the recommendation by the Cystic Fibrosis Foundation. Another common one is lung disease, as we discussed. Chronic bacterial infections of the lung can actually be associated with adiposity and reduced growth. And there's also, it causes a reduction in calories to be consumed because the constant symptoms associated with having lung infections include constant nasal drainage, persistent cough, and blunted smell and taste. So it can be very difficult for patients to consume adequate calories. Then there's gastroesophageal reflux disease, also known as GERD. Up to 80% of CF patients have this, and it's also very commonly found in children with CF. It's one of the more challenging symptoms to treat, and it includes contributing factors such as increased pressure from lung disease, increased pressure from coughing, side effects from medications, high-fat diets, and G-tube feeding side effects. So next, going over nutrition interventions. Overall, it's important for patients to have an increased energy intake. As Emily discussed, about 110 to 200% is recommended daily, and with additional increases in protein and fat as well. With age, these increases will go up with the progression of the disease. And if PERTs and PERTs and dietary modifications are not sufficient to meeting their needs, oral supplementation will be used. So about 40% of patients require this, according to the Cystic Fibrosis Foundation. And they're given a supplement in the form of, basically fat-soluble vitamins will be in the form of a water-miscible form so that they can absorb it. And then there's also the chance that patients will develop deficiencies in certain vitamins, and so they will be given specific higher doses of vitamins in this case. Focus of education, I won't read through this all, but they're generally designed to prevent malnutrition, manage symptoms, and avoid infections, which is very important. So infection control, clearance therapies, that's all important. And then you guys can read through the rest. For coordination of care, a lot of professionals are involved, a lot of experts are involved here. So a patient definitely needs a physician and an RDN on hand. Social workers can be helpful, nurses, of course, and genetic counselors may be used, endocrinologists may be used, and even mental health coordinators, because as we see with patients, they are at higher risk for mental health disorders such as anxiety, depression, especially for adolescents. There's a lot of isolation, a lot of worry with what they're going through. So they have to be isolated from social events a lot, and so they're definitely in need of mental health care at this time. So a number of measurable outcomes are useful in monitoring CF for management or disease progression. About every 6 months, so semi-annual visits are key for, and in-person visits are key for patients 6 and older, although they can be seen more frequently if needed. Some of the evaluation will go over routine pulmonary function testing or spirometry, sputum cultures, DEXA scans for bone density monitoring, fat soluble vitamin testing, and BMI. For the evidence analysis library, I'm not going to read through this whole thing. I'll let you guys read it if you want to. But generally speaking, the assessment and intervention ratings were given consensus and conditional because a lot of this disease is very individualistic for each patient. So we noticed that grading was very common in assessment and intervention. For areas of future research, we found cardiovascular disease was a big one mentioned in the most recent studies, since there's a lot of high dietary fats needed for energy. There and also due to the fact that there's more longevity in patients, there's people are living longer. It means that more diseases are people are able to live long enough to see some secondary diseases pop up. So obesity has been more of an issue lately with some of these patients, and so quality of fats has definitely been something that um, professionals want to make sure that patients are adhering to prevent cardiovascular disease risk. And for the next one, we have essential fatty acid deficiency because it's been shown that PERTs or PERTs do not correct this deficiency. There's been studies done to see how to treat essential fatty acid deficiency using omegas as supplements, but there isn't quite a consensus or conclusive information according to recent studies. So that's kind of been up in the air and a good area for future research. And then with probiotics, there's kind of some mixed data on this as well. As we saw with our case study, um, the studies, there's not been enough long-term studies, robust data, um, consistent design methods used to really determine a good use of probiotics for this population. So that's areas for future research. And this is our references. And on to our case study.
Thank you, Sophia, and I hope everyone was paying attention. So our patient today is Miss Linda Lawley. Linda is 2 months post-op after receiving a lung transplant. Her current medications include PERT, mycophenolate mofetil, Decas, and an oral antibiotic. She has a genetic variation that does not currently have a CFTR modulator medication available.
Since the surgery, she hasn't been going outside other than frequent trips to the hospital for checkups and has been trying to take it easy at home as she recovers and has been having a difficult time adjusting. Before the lung transplant referral, her weight was consistently 125 pounds. When her health started to decline, her weight dropped to 108 pounds. Since the lung transplant operation, she's gained some weight and hopes to get back to her usual body weight of 125 pounds. She does have a gym at her apartment, but hasn't quite gathered the courage to go.
Here is all the pertinent info from Linda's latest routine checkup. Feel free to pause the video here or go back and forth after finishing the video to answer the questions.
And here are some questions for you guys to go over and ponder. We hope that you enjoyed our presentation, and we look forward to any questions you may have and any comments and looking at your responses. We look forward to it. Thank you so much.